All right, welcome everybody to another EBFA webinar. My name is Dr. Emily Splichal. I am the founder of the Evidence-Based Fitness Academy, and I am a podiatrist and human movement specialist in New York. If this is your first time tuning in to a EBFA webinar, very special welcome. And if you are returning, then we of course appreciate your continued support. So the way that the webinars work for 2013 is that they are actually sponsored, which means that you tuning in are now able to win some prizes. So what we have this year is, or for this webinar, is Toe Socks as the sponsor. So as we go through the webinar, we're going to have some little pop quizzes that you guys have the opportunity to answer. And if you answer them correctly, then you win a pair of toe socks. So we will get started. This one, again, is on barefoot science, a role in the rehab setting. All right, so if you are new to kind of the barefoot running or the barefoot movement, an area that I'm very passionate about, an area that I'm very passionate about as it relates to barefoot science is more in really the rehab setting and the role that it plays on total body strength, proprioception, co-activation patterns, etc., beyond just this barefoot running. Okay, sorry, I just want to make sure that everybody can hear. Okay, so I think everybody can hear. If you cannot hear, then somebody just let me know. Anyway, so we will continue. So barefoot running and kind of the minimalist movement. And my goal through both the Evidence-Based Fitness Academy and research that I'm involved in is to change the concept of, or the mindset of when people hear barefoot training. A lot of people go to that barefoot running. They think of Vibrams and Nike Frees and all these minimalist shoes, but there's so much power behind barefoot science, and we're trying to explore and really get it out there to both the athletic performance, rehab specialists, and then, of course, in the fitness industry. So, little brief history about barefoot science and barefoot running is that it's really not a new concept. It's been around for quite a while. The first time that people really kind of were introduced to the concept of barefoot running was in the 1960s when Abebe won the Olympic marathon and he ran it barefoot. So that kind of brought this initial highlight or the initial introduction to the concept of barefoot running. And then as far as barefoot science and the negative impact of shoes on the proprioceptive system and human movement really was started in the 1980s. So again, not a totally new concept. A lot of this research was done by Stephen Robbins, his research is amazing. And I really apply a lot of his research when I do my education, when I treat my patients, etc. You can learn more about his programming on StephenRobbinsMD.com. And then into the 1990s is when Dr. Yonda started introducing his research, and he is the big guru on a lot of the barefoot or foot stimulation and the way that that ties into hip and glute pelvic floor activation. And again, great research, and I apply a lot of his research into my education, patient care, etc. If we go back into the barefoot running and kind of where it's come at the forefront in the past decade was when all of these shoe companies started recognizing that athletes are training barefoot and that they could have a specialty kind of minimal shoe line. Nike was actually the first one to introduce them, and they did that around 2004, 2005. And then Vibram followed shortly after, also in 2005. And then it didn't really kind of pick up or take off until the whole Born to Run by Chris McDougall, and then a lot of the research out of Harvard with Daniel Lieberman and kind of that group. So this focus of the webinar, again, is going to be in using the barefoot science for the rehab setting. And again, a lot of the the application of this is based off of the research by Dr. Yanda. And if you're not familiar with Dr. Yanda, I highly recommend checking out his research. Great research. Again, it's all about human movement, foot stimulation. The foot is the foundation, and we really should start a lot of our corrective exercise or movement dysfunction programming from the foot up. And he really is the father of what's called sensory motor training. And he traveled around, did a lot of research, and has a lot of textbooks on the inability to separate the sensory system and the motor system. So really, whenever we're doing training, you are training the nervous system at the exact same time. And he believed that the first step in corrective programming or corrective exercise programming is that you had to normalize the peripheral proprioceptive structures. And I strongly believe in his approach. I apply his approach again with my patients and in my education. And if we take that kind of concept of the first step being normalizing that peripheral proprioceptive system, that would greatly relate to then our barefoot science. So, benefits of barefoot science in the rehab setting. What we're doing is we're looking at, or we're thinking about the term barefoot science as a form of neuromuscular training. And what we're doing when we train the nervous system is that we're actually training or creating reflex motor patterns. So it's almost like a coach telling their athlete and kind of like pounding into them their form of your trainer, and you're like shoulders back, abs engaged, this, that, little bend in the knees, however you're cueing the form. What you're trying to do is consciously make that client aware of their movement patterns and their muscle activation patterns so that it then becomes part of their subcortical or their subconscious movement pattern. And then that exact same thing goes with the barefoot science. So we're trying to get this bottom of the foot stimulation to then create reflex motor patterns that then make the patient or the client stronger, are preventing injuries, and are then truly improving their movement function. So we have our first flash quiz. The way that it works again is that we will have a little question. Hopefully your fingers are near your keyboard, so then if you are the first one to answer, you will win a pair of toe socks. And these are fabulous socks, and I love their marketing, so why would you not want a pair? All right, so here we go. First question, which of the following muscles in the foot, which of the following muscles is not, I apologize, an intrinsic muscle of the foot? The abductor hallucis, extensor hallucis brevis, pronis tertius, or quadratus plantae. Which of these four muscles is not an intrinsic muscle? So again, the first person who answers, Daniel Hansen, congratulations. You won the first pair of toe socks. All right, so we are moving on. So again, the focus of our barefoot science in a rehab setting is creating these reflex motor patterns or creating reflex motor control. And to understand the concept of reflex motor controls, you need to understand and appreciate the difference between closed loop system and an open loop system. Now, the closed loop system is, these are actually flip-flopped. The closed looped one is the reactive, and the open loop system is the preparatory. So again, closed loop, reactive. The best example of this one is that if you're walking and you accidentally step off of the curb, or you step on a pebble or a rock, and your foot starts to move into subtalar joint inversion, almost as if you are about to sprain your ankle. And then your peroneal tendons, the musculotendon junction, senses that inversion moment. It senses that stretch. It sends that afferent signal to your spinal cord. And then your spinal cord, or your central nervous system, sends a signal back down to the motor neurons and then causes a contraction to pull the subtalar joint or the ankle out of that inversion. And that would be an example of that closed loop or reactive system. And a lot of rehab programming, not just ankle, but that's probably the best example, is reactive. And the thing about reactive, if we were to compare this to the preparatory or the open loop, is that reactive is actually slower. And oftentimes there's some really good research showing that reactive or the closed loop system is actually too slow to prevent injuries. So that means if you're dealing with the prevention of injuries, you're dealing with these athletes who are at high speeds and are at high risk of different injuries, it's all about the timing, and it really is all about being one step ahead of the injury. So that would then bring us to the second type, which is the open loop. And this would be the pre-activation, or it's almost preemptive. And what this means is that the muscles actually contract. Again, I use the ankle, here's the example, but the muscles actually contract before the foot would even strike the ground, or before that athlete or that client or patient makes a move. And all of these pre-activation patterns are created off of previously experienced movement patterns. So I don't know if anyone is kind of a motor learning geek or junkie like I am. I love learning and reading about motor learning and motor control. And the best analogy is on the transfer of learning. So that means that if our mind or our nervous system could mean also these peripheral nerves, have experienced a movement pattern, then when you're in a certain activity and they have experienced it before, they will be able to recognize and contract at a faster rate. So same thing applies here. So what we need to do is train this pre-activation or this open loop system. This is the one that's faster than that closed loop. And if we are looking at the open loop, that really is, again, we're applying that barefoot science. The plantar proprioceptors of the foot are faster than the musculotendon junction. Again, they're different types of nerves. If anyone has studied and looked at the different alpha versus beta or small nerves versus large nerves, it really is those small nerves on the bottom of the foot that are faster in getting that initial stimulation. And then that's how you're going to prevent those injuries. So what we're going to do is we're going to take a concept from the ground up. We're starting with the foot. We're taking the shoes off, the socks off, the Vibrams off, and we want to be totally barefoot so that we can start from the ground up from a neuromuscular perspective. So some of the benefits and ways that we can start applying barefoot science in our clients, patients, and athletes is, first one, to improve foot posture. Barefoot training and barefoot science can improve foot posture. What does this mean, and what type of patients would that be perfect for? Barefoot training and barefoot science can also improve balance and stability. That one is probably the most common sense one. And which of those clients or patients is that appropriate for? And then the final example that we'll go into is that barefoot training and barefoot science can improve total body strength. And then again, which patients or clients would that be perfect for? First example is barefoot training, barefoot science can improve foot posture. And this means that if we begin to train the intrinsic muscles, specifically the abductor hallucis, you can begin to increase a foot's arch height. There's some great research about it. One of the research studies below by Stephen Robbins, down on the bottom, again, you can note the date of it, 1987. So he's already been exploring some of these concepts way back into the 80s. So as we pick up the arch, because the abductor hallucis originates on the inside of the calcaneus, or the medial aspect of the calcaneus, that means when it contracts, it's going to start pulling the subtalar joint and the foot into supination. So many causes of knee injury, patellofemoral pain syndrome, medial knee syndrome, ACL injury risk are all because of improper knee mechanics, and a lot of that is driven from inadequate subtalar joint control. So if we can better control that subtalar joint by that initial contraction of that abductor hallucis, perhaps that patient and athlete would be at a decreased risk of injury. Awesome exercise. Yonda Shortfoot, again, mentioned him in the beginning. Dr. Yonda, great work. This exercise specifically targets the abductor hallucis. So I have all of my patients, almost all, and I hope they are doing it when I tell them to do it, is they're doing the yawn to short foot exercise. So I can explain kind of a little bit about how to do it, but I recommend it might be easier to Google it or YouTube it and see a video. But you're essentially pulling the foot, making it short by engaging that abductor hallucis. You're pressing the big toe down or the hallux down without contracting the lesser digits. And then when you do it properly, you should feel or notice that the medial arch will increase as well as the transverse arch. So that means now you're doming and create a very strong foundation. When you're good at this, or if you have very good mind-muscle kind of connection, that you will feel your abdominals engage and you will feel your glutes engage, which is super cool. I actually have been doing the on to short foot when I teach my fitness classes, and then I went to the gym yesterday and I was doing back and legs and every exercise I did. Even though I had my minimalist shoes on, I was getting this short foot. It's totally a reflex. I didn't even think about it, and that's like my foot is engaging, and I felt much more stronger and controlled in my core. So awesome research on that as well. So applications of barefoot science specifically on how it can improve foot posture. This is perfect for those patients suffering with posterior tibial tendinitis, plantar fasciitis, sinus tarsi syndrome, patellofemoral pain syndrome, ACL injury, or low back pain. All of these patients, I would be getting them doing that short foot exercise. Starting with that, get those shoes off and starting to get a connection from the bottom of the foot. So, next flash quiz, get your fingers ready so that you can type it. Again, the first person who answers this correctly wins an awesome pair of toe socks. Are we ready? So, at its insertion, how many attachments does the posterior tibialis muscle have? Again, how many attachments does the posterior tibialis muscle have? 1, 5, 9, or 15? How many attachments? Oh, who answered 9? It was Anita Langinger. Congratulations, Anita. Yes, the posterior tibialis has 9 attachments. Its first attachment is on the navicular, and then it fans out, and it attaches to almost every bone in the midfoot, to the pronator longus tendon, as well as the flexor hallucis brevis. So now we are moving on to the next application of barefoot science. And what we are talking about is how we can improve balance and stabilization. So for improving balance and stabilization, we have plantar receptors on the bottom of the foot. They play a key role in balance and stabilization. There's an awesome study that looked at, and I mentioned this a little bit before, but we have both small nerves and large nerves that supply the foot and the ankle. The large nerves actually supply that musculotendon junction. This is where we have the muscle spindles, the GTO. Those are the large nerve fibers. And then the small nerve fibers are very specific to the skin on the bottom of the foot. And that skin on the bottom of the foot plays a very important role in quiet stance and in our static balance. So if we're looking at patients that may have small nerve neuropathy, if anyone is a physical therapist and works with anyone with maybe diabetic peripheral neuropathy, Charcot-Marie tooth, etc., then they would kind of recognize the difference between the small nerve and the large nerve. But what this does is it really shows that the plantar skin is so critical for balance and stabilization. There's some other studies that have shown that patients with an ankle sprain, functional ankle instability, or kind of chronic ankle pains, they get repetitive ankle injuries, have a decreased small nerve fiber response, which means that in those patients, you have got to start doing some sort of proprioceptive training with their feet barefoot, and you want it to be specific to the receptors that are on the bottom of the foot. So if we look at the receptors and what they respond to, we actually want to be specific. So we have all these Ruffini's, Merkel disc, Puccini, and Meissner's, things that, maybe you guys don't want to remember, and I don't remember them either. But if we remember that these receptors respond to skin stretch and texture perception, deep pressure, vibration, light touch. And if you can start integrating these different types of sensory input with your patients, clients, or athletes, you are specifically targeting each of these individual receptors. Skin stretch, awesome. I mention this a lot in some of my courses and education, etc., is that skin stretch, if somebody has a history of an ankle sprain or ankle instability, what I have them do when I send them to the physical therapist is I have them do a J strap. So you're just doing a J strap with non-elastic tapes. You're not using kinesio tape. And you're just going from one side of the subtalar joint to the other side. And then as that subtalar joint moves and they're noticing or they're feeling that inversion, eversion moment, you're actually stimulating the skin. So you're stretching the skin. And that skin stretch is faster than relying on the peroneal tendon to sense that inversion moment. You also want to do the different textures. You want to have them be responding to vibration. So any sort of power plate or vibration platform, perfect, awesome. When we walk, we respond to vibrations. That's what ground reaction forces are. So every step that we take or every step that your athlete maybe takes is vibrations that they must deal with. Those vibrations go from the skin into the intrinsic muscles, and then those intrinsic muscles initiate some sort of contraction that is then translated into the extrinsic muscles. So everything is integrated, and it truly does start with the skin on the bottom of the foot. So ways that we can start applying that benefit of barefoot science in the rehab setting is, as I mentioned, functional ankle instability. Every single patient who has functional ankle instability should be barefoot. And I go around and I speak to physical therapists, and they have to do their ankle rehab barefoot. How about our patients with peripheral neuropathy, Charcot-Marie-Tooth, diabetic peripheral neuropathy, any of those nerve dysfunctions? You can still stimulate some of those nerves. Nerves grow back. Nerves definitely grow back. I have patients with diabetic neuropathy. I have them doing their rehab. I'm putting them on vitamin supplementation, and they are showing that they're growing their nerves back. There's a lot of research on that as well. If you want to hear more about it or you want the research, 100% email me and I will send it to you. Anyone with an ACL injury, so now we're stimulating the proprioceptors of the knee joint, and then low back pain. Low back pain and how that would relate to that proprioceptors, again, was previously mentioned by Dr. Yonda, is that a lot of our muscle dysfunction has to be first corrected by stabilizing all of those joints. All of our joints are stabilized by peripheral stimulation. So, perfect application. Last one that we're going to go over, and this is the one that is of great interest to me, is how barefoot science or barefoot training can improve total body strength. So barefoot stimulation creates a reflex activation to the pelvic floor and the deep hip stabilizers. So there's this concept, again, it was really hit home by Dr. Yonda, and then a lot of movement specialists now kind of speak of this, is that we need proximal stability for distal mobility. And this must happen every single time we take a step. What's interesting is that when you stimulate the bottom of the foot, when you do that short foot exercise that we mentioned, you get a reflex activation in the pelvic floor. Your pelvic floor is myofascially connected to your deep hip stabilizers. Your deep hip stabilizers are myofascially connected to your psoas muscle. Your psoas is then fascially connected to your diaphragm. Everything is interconnected. That is the foundation of your lumbopelvic hip stability. And guess what? It's initiated from the bottom of the foot, which makes sense because we are walking, we're striking the ground, and then as our body responds to those ground reaction forces or presses us forward or jumps, etc., we have to have a strong, controlled lumbopelvic hip complex. So, the role of rehab and hip, knee, foot injury is all about the timing of these muscle activation patterns. So again, if you can get the shoes off and get that stimulation or get the bottom of the foot and start stimulating that neuromuscular system, get it to be a reflex, get those muscles firing faster, the client, patient, or athlete will then stabilize their lumbopelvic hip complex a little bit faster, which then means their knee will be stable, their foot, etc. So it's all about the timing. Perfect applications for this are SI joint dysfunction, hip labral injury. This is a huge one. Most hip labral tears are in the anterior direction, which means that that hip is destabilized, and as they're doing a certain movement, that femoral head is driving forward or anteriorly into that labrum, and it's resulting in a tear. So again, any of those patients dealing with any sort of hip labral issue, groin injuries, that psoas dysfunction, again, going back to those groin injuries, huge in hockey, soccer, football. ACL injuries, ACL is all about timing. Timing. You have to get that hip stabilized a little bit faster, that foot stabilized, and then again, functional ankle instability, perfect, it makes sense. So again, I hope that this kind of creates some sort of thought process on the benefit and the power behind barefoot science. I know a lot of the kind of media and mainstream way of looking at barefoot science is through running, and it's a perfect application for barefoot science. But I think that there's so much power behind barefoot science from a rehab standpoint, and especially from an athletic performance standpoint, whether it's athletic performance or the prevention of injuries in our athletes, kind of both of those together. I think barefoot science is perfect. Start getting the athletes to take off their shoes, do some sort of neuromuscular warm-up, get the shoes on, and then go practice or go compete. And you have all of those neural muscle activation patterns already fired up and ready to go and stabilize or to react to the ground. So very, very important. So last quiz again. How it works is you are going to type in the answer. The person who answers it first or the fastest wins a pair of toe socks. Here we go. According to a 2007 study, what percent of elite runners run with a midfoot strike pattern? Was it 17%, 24%, 36%, or 48%? How many elite runners do you think run with a midfoot strike pattern? Let's see who got it. Oh, Rebecca. Congratulations, Rebecca Melandra. You won your pair of toe socks. It is 24% ran, which I was actually a little surprised. I thought it would be a little bit higher. But this, again, was what they found in a 2007 study. If you want to copy this study, I can definitely get it for you. So if you want some more great tips on building foot strength or applying barefoot science for your patients, clients, or athletes, please check out the website, ebfafitness.com. We have both the V-Core workout, which is a certification. That is my barefoot balance training certification. And then we have, of course, our barefoot training specialist certification with workshops happening every month around the country and around the world. So please check out ebfafitness.com. If anybody has any questions, you can type them in and I will be more than happy to go over them. All right, so we have a question. Do you use short foot in cavus foot patients as well as flat feet? Also, high does the J-strap go for ankle instability go? All right, so as far as doing the short foot in a cavus foot or a high arch foot, as opposed to just a flat foot, 100% I do. And I use the short foot for a flat foot when I'm actually trying to do a very specific foot strengthening program. That's where I love it for a flat foot. For a high arch foot, what I'm trying to do is do movements where they're initiating it from the floor up. So let's say your client or patient is doing squats and they have a high arch foot. They're going to initiate that squat with the short foot. So they're still, even though they have the high arch foot, what you're trying to do is drive home that reflex activation pattern so that as as they engage that short foot and they begin to press out of that squat, their pelvic floor, their deep hip is stabilized, and then they can get better activation out of their glutes. So that's really the pattern that I'm training. Same thing goes for the flat foot, is part of their foot strengthening program, but then exact same thing. They're doing that short foot as they initiate the movement so that they have that stability and then create that pattern. As far as the J strap and how high it goes, I go just, a couple inches above the malleoli. And the purpose is more that you're trying to get that subtalar joint motion versus, you don't have to go to the middle of the calf on either side. It's again stimulating that. You're not using any pre-wrap. You're doing just straight skin tape, kind of that old school white athletic tape, so that it does not stretch. And then that's you're trying to stimulate. So very good question. All right. What do you recommend for short foot in terms of sets and reps when writing a program for a client? I have them, depending on the foot type, I will have them do an isometric short foot, which means they're holding it 8 to 10 seconds. They're doing around 4 to 5 repetitions. If I'm trying to build endurance, then I will have them, rep it out. So they're doing short foot over and over. I've also told several of you who have attended some of my workshops is that I'll have patients do short foot on one foot while brushing their teeth. So it's a great way that they can sneak it in every day. If they're doing it first thing in the morning, barefoot on one foot, and they're doing the short foot, guess what? They're activating their foot, their hip, their pelvic floor. So then when they go walk to work or etc., they have kind of they're waking up the body for the day, which is why I love it in that sense. As far as additionally integrating it into their program is that every single move that they're doing, whether they're doing bicep curls, squats, military press, I want that movement to be initiated with a short foot. And if they have shoes on, they have minimalist shoes, they have Vibrams, they can still do that short foot. The only way that they could probably not do a short foot as well is if they had kind of a really controlling orthotic with a high medial arch. But I really try and build it in that way. So every movement is initiated from the ground up. Okay. Is your J-strap just for proprioception, or do you use it to also correct subtalar joint motion? That is a very good question. I do it for, I guess that would be patient specific. Where I had mentioned it for the skin stretch, that one would be just specific for proprioception. So that would be more, say they have a neutral foot and they just happen to sprain their ankle. Then I don't necessarily want to limit the subtalar joint or correct subtalar joint motion. Say they had excessive subtalar joint eversion, and then I want to pull them into kind of that more neutral position while training their proprioceptive system. 100%. If you can get two things out of that J-strap, I definitely would. All right. Is there any research that shows how barefoot rehab transfers to shod foot activities for speed, balance, and agility? Alan, that is an awesome question. And if you want to do that research with me, then send me an email because I'm 100% interested in it. But right now there is not. I am initiating research with a urological gynecologist who specializes in the pelvic floor. And he has an EMG system very specific to the pelvic floor. And what we're going to look at is barefoot movements compared to minimalist movement, compared to your traditional shoes, and really how that relates to pelvic floor activation. So that's something that I'm getting involved in, but I love that idea, Alan. If you want to get involved as well, I would love it because I know you have a great background. And anybody else, 100%. So I will very good question, Neff. Last question, and then I don't want to take too much of everybody's time. Neff had a great question. Is short foot recommended to do on power plate? 100%. If you can get stimulation of the vibration proprioceptors or the vibration specific proprioceptors at the exact same time as doing that short foot and strengthening the abductor hallucis, to me, it's like a win-win. So awesome idea. And you're restoring that proper foot movement. You could even do reps instead of just holding that isometric short foot, but do different reps and have them really feel how their pelvic floor and their hip and their glutes activate when they do that repetition. So awesome job. Again, congratulations to everybody who won the pair of toe socks. Again, every webinar is sponsored. Next month, we have a great webinar with Rick Daigle, who will be speaking about myofascial kinesiotaping and functional movement. So please tune in. If you have any questions or you want a copy of the webinar, we always offer them. Can be emailed to education@ebfafitness.com, and I will shoot you the PowerPoint. Please check out our other webinars at youtube.com/EBFA Fitness. Have a wonderful night, and thank you all.